Hello everyone, today we'll be discussing Wilson's disease. Wilson disease or hepatolenticular degeneration is an autosomal recessive disease which results in an excess copper buildup in the body. This condition primarily affects the liver and the basal ganglia of the brain, but it can affect other organ systems too. Wilson disease is an autosomal recessive condition that's caused by a mutation in the Wilson disease protein, which is the ATP7B gene. Etiology: Wilson disease is caused by one of the several mutations in ATP7B gene that is present on chromosome 13, which controls the protein transporter responsible for excreting excess copper into bile and out of the body. So the protein transporter is located in the trans-Golgi network of the liver and brain. So the major route of copper excretion, 95%, is through the liver. The excess copper first accumulates in the liver and then spills into the blood and then to other organ systems. So basically the gene in which there is a mutation is the ATP7B gene, okay, which is present on chromosome 13. So what does this protein do? Or this gene code for? It codes for the protein transporter that's responsible for excreting excess copper. So what it does is it excretes excess copper into bile and out of the body. And what we need to know is copper excretion, which is 95%, is through the liver. So when there is a mutation in the ATP7B gene, that will result in accumulation of copper. So the pathophysiology, in Wilson disease there is a faulty copper excretory mechanism causing copper to accumulate in the liver and spill into the blood, where it begins to accumulate in other organs and tissues like the subthalamus, putamen, and cortex of the brain, kidneys, and the cornea. Copper is a transition metal, and excess copper levels lead to the formation of a toxic hydroxyl group, and this leads to an increase in the oxidative stress in the cells. So we generally know that oxidative stress damages cells and leads to the clinical manifestation, which is liver failure. Will also present with behavioral problems, movement disorders, and case of Fleischer rings in the cornea. When the copper level in the liver overwhelms the proteins that normally bind it, it results in oxidative damage through a process known as Fenton chemistry. This damage results in chronic active hepatitis, fibrosis, and liver cirrhosis. The liver releases copper into the bloodstream that is not bound to ceruloplasmin. This free copper precipitates throughout the body, particularly in the kidneys, eyes, and the brain. In the brain, copper is deposited in the basal ganglia, putamen, and globus pallidus. These areas participate in the coordination of movement and neurocognitive processes, such as stimulating mood regulation. Therefore, damage to these areas produces the neuropsychiatric symptoms that are often seen in Wilson disease. So when you look at history and physical examination, you will note there will be a positive family history. Patients may complain of abdominal pain, jaundice, weakness, personality changes, depression, migraine headaches, insomnia, seizure, and movement disorder, chorea. Hemibellismus may also be present in history. About 30 to 50% of patients will have neuropsychiatric symptoms, including asymmetrical tremor. Other symptoms may include drooling, ataxia, personality changes, mask-like faces, and clumsiness. On physical exam, the patient may have features of hepatosplenomegaly, isolated splenomegaly, or if the disease has progressed to cirrhosis, then stigmata of chronic liver disease may also be prominent. An eye exam may reveal icterus of sclera and slit lamp exam for case of Fleischer rings on the cornea, which you can see on the side. Other features of Wilson disease may include the presence of movement disorders, difficulty in speaking, mask-like faces, spasticity, muscle rigidity, and skin findings of lunulae, cerulae, which is bluish discoloration at the base of fingernails. Skeletal involvement is very common in Wilson disease and resembles premature osteoarthritis. Hemolytic anemia is seen in 10 to 15% of patients and is due to red cell lysis by the high copper concentration. Evaluation of a patient you suspect to have Wilson disease. So you need to order a ceruloplasmin level. So it will be less than 20 milligrams per deciliter. Normal values are between 20 milligrams per deciliter to 40 milligrams per deciliter. Urinary copper levels will be raised more than 100 mcg per deciliter. These two lab findings with cases Fleischer rings are usually enough for diagnosis. ECG may be noted to reveal ventricular hypertrophy, arrhythmias, and non-specific changes in T waves and ST segments. The gold standard for diagnosis of Wilson's disease is a liver biopsy. Treatment of Wilson's disease. So the mainstay therapy for Wilson's disease is copper chelation therapy, that is done with penicillamine and trientine. For muscle rigidity, spasticity, and Parkinsonian features, baclofen, anticholinergic such as trihexyphenidat, GABA antagonist, and levodopa may be used. Liver transplantation seemed to have been beneficial in improving neurological dysfunction in some patients that are not responding adequately to medical therapy. A diet low in copper-containing foods is recommended, with avoidance of mushrooms, chocolate, nuts, dried fruit, liver, and shellfish. Staging of Wilson disease. So stage 1 is initial accumulation of copper in the liver. Stage 2, acute redistribution of copper within the liver, followed by release into the systemic circulation. Stage 3, chronic accumulation of copper into extrahepatic tissues, including the brain. Stage 4, use of chelation therapy to restore copper balance. Complications of Wilson's disease include liver failure, encephalopathy, splenomegaly, ascites, variceal bleeding, hepatorenal syndrome, liver failure, neuropsychiatric manifestations, and death. So that's all about Wilson's disease. Thank you.